Hi, my name is Jamie Upchurch. I'm a student at Liberty University working to obtain my master's in nursing administration, and I'm going to be discussing the importance of implementing provider and triage in the emergency department setting. After the Department of Veteran Affairs was accused of negligence in 2014, President Barack Obama appointed Mr. Robert McDonald as the Secretary of Veteran Affairs. Over the past 2 years, Mr. McDonald has worked to transform the VA through the implementation of the My VA initiative. This initiative encompasses 12 breakthrough priorities, 3 of which are focused on improving the veteran's experience, improving the employee's experience, and increasing veterans' access to health care. The My VA initiative is focused on transformational strategies that can improve the overall care that veterans receive at the VA. These strategies focus on rebuilding the trust our veterans have with the healthcare system, and not only focusing on veterans, but also their families. These strategies look at the VA from the veteran's perspective and ensure that we are doing everything that we can to improve the veteran's experience and improve how we emotionally engage with these veterans. A department-wide transformation focuses on putting veterans in control of how, when, and where they wish to be served within the healthcare system. To improve the employee's experience, the My VA initiative is focusing on modernizing the culture of the VA and implementing process improvements to improve the care the veterans receive. We are focusing on building a high-performance organization where veterans want to receive care. In doing this, we must build on the strengths to promote an environment in which VA employees see themselves as members of the single enterprise and fortify diverse backgrounds, skills, and abilities. In doing this, the employees must understand how everyone fits into the picture of the My VA initiative and how we all can improve the VA to improve the veterans' care that they receive. The priorities of improving access to health care and improving the veterans' overall experience are directly related to the Institute of Medicine's 6 aims that focus on providing safe, effective, patient-centered, timely, efficient, and equitable care. These same priorities are directly related to the mission of the VA, which is to serve America's veterans while upholding the values of integrity, commitment, advocacy, respect, and excellence. These initiatives and values spell out I care. When employees of the VA act with integrity, they act with a high moral principle, and they are committed to working diligently to serve others, and they must advance the interest of the veterans by advocating for care that the veterans should be receiving. It is ultimately important that everyone within the VA system respects and treats everyone with dignity. As employees of the VA system, we must strive for excellence in providing high-quality, continuous improvement. Although it can be challenging, it is important for employees to strive to carry out the mission of the VA and provide excellent care at all times. The emergency department is a very dynamic environment that can change at any given moment. This can create a very intense and stressful environment for staff who work in this area. Due to the acuity level of patients who arrive, staff must be prepared for any situation. In the emergency department, patients present with complaints that vary from cough and chest congestion or knee pain, all the way to strokes, chest pain, and respiratory distress. Therefore, staff must be prepared at all times for any situation that they may encounter because the ED can become quickly inundated with several high acuity patients at any given time. Unfortunately, there are times when the emergency department can become overcrowded. Bottlenecks in the emergency department are typically created when patients in the ED are being admitted. However, there are no beds available in the hospital to transfer patients to. Yet, veterans continue to present to the ED for treatment. However, these patients cannot be treated in the emergency department because there are no beds available in the ED due to borders. During these times of congestion, the length of stay in the emergency department increases, wait times are increased, and these result in veterans leaving without being seen or evaluated by a provider, and also results in decreased patient satisfaction. This is one of the reasons, the primary reason, why implementing provider and triage is very pivotal in the ED setting. When veterans arrive to the emergency department, they are evaluated by a triage nurse and assigned an emergency severity index level. Veterans assigned as an ESI level 1 are most critical and require immediate medical care. Veterans assigned an ESI level 2 or 3 require medical attention, but their condition is not immediately life-threatening. A veteran with an ESI level 4 typically requires one resource, and an ESI level 5 typically does not require any resources. Because of their low acuity, veterans with ESI levels 4 or 5 often endure extended wait times due to ED overcrowding. Long wait times are a major reason why veterans leave the emergency department without being evaluated by a healthcare provider or left without being seen. Veterans who leave without being seen are at risk for worsening morbidity due to delays in diagnosing and treating their conditions. Because emergency department overcrowding and left without being seen negatively impact the Institute of Medicine's 6 aims, the Center for Medicare and Medicaid Service recognizes left without being seen rates as an important ED quality metric and is now requiring that hospitals report this metric annually. Implementing provider and triage could improve the veterans' experience, increase their access to health care, and decrease the volume of veterans who leave without being seen by a provider. Provider and triage, or PIT, is a rapid process improvement which focuses on deploying either a physician, nurse practitioner, or physician's assistant to a designated section of the ED waiting area to evaluate patients. The provider's primary responsibility would be to assess, treat, and discharge low acuity patients in an efficient manner from the emergency department waiting area. These providers would offer a rapid episode of care, which would include a quick assessment, labs or x-rays if indicated, and would also have the capability of refilling medication prescriptions in the emergency department waiting area. The patients who would be treated in the PIT area would typically be triaged with an ESI level either 4 or 5. As you can see, ESI level 4 patients typically require one resource. One resource would be either an X-ray or some type of lab. ESI level 5 patients do not require any resources. Typically, that would be patients who are receiving medication refills or like a consult, audiology consult or a psychiatry consult. Low acuity patients, 4 and 5, typically are patients who present with chronic back or joint pain, cough, cold, chest congestion, otherwise well-appearing ambulatory patients who do not require a stretcher or further evaluation by a provider. As you can see in the graph indicated, a level 1 patient, as mentioned earlier, is someone who is having a life-threatening emergency. Cardiac arrest, respiratory arrest, and CPR is actively in progress. Level 2s and 3s are patients who do require rapid episode of care, yet their life is not in immediate danger. Level 4s and 5s, as indicated, are ambulatory, well-appearing patients who you anticipate will be discharged from the hospital. In this diagram, you can see where the provider in triage would be located for the Durham VA Emergency Department. The process would be that the patient would come in through the entrance. They would then present to nurse first and provide their chief complaint. And then after the patient is registered, they would go to triage, be evaluated and provided an ESI level by the triage nurse. And then if indicated, the provider in triage would see ESI level 4 or 5 patients. After meeting with the emergency department quality improvement nurse and the chief medical director, Dr. Villani, it was indicated that the PIT would be implemented during the peak hours of emergency department overcrowding. For the Durham VA Emergency Department, those hours are typically Monday through Friday from noon to 8 p.m. At the Durham VA, we typically see an influx of patients during clinic hours, and those patients are generally patients who have presented without an appointment to their primary care and do not have availability, or a patient who did have an appointment who was sicker than initially indicated. After implementing initiatives such as PIT to improve patient flow, it is essential for administrators to assess the productivity and efficiency of the implementation. When assessing the efficiency of PIT, it would be important to evaluate and compare emergency department metrics to prior data. Metrics to consider would be the time from door to physician evaluation, the volume of left without being seens, and the average length of stay for emergency department patients. As part of the MyVA initiative, VA administrators should also evaluate whether or not the veteran's experience was improved and if the veteran's access to health care was increased. Although the VA is working to increase same-day access to care, veterans struggle to obtain same-day appointments with their primary care physicians. Therefore, they utilize the resources of the emergency department to obtain the care they need. Unfortunately, this care is not considered emergent, so these veterans are triaged as ESI levels 4 or 5. When the ED is overcrowded, they may wait for more than 4 hours to see a provider. These are the patients the PIT provider could rapidly assess and discharge from the waiting area. Without provider and triage, these patients would likely leave without being seen due to lengthy wait times. Therefore, we should evaluate the goals of implementing PIT, which you see here on the screen. The implementation of provider and triage directly relates to the American Nurses Association Scope and Standards of Practice for Nursing Administration. Throughout my clinical practicum and while working in the emergency department at the Durham VA, I was able to identify that the majority of veterans who leave without being seen are sent from the clinics and triaged in the emergency department as emergency severity index levels 4 and 5. Throughout this project, I was able to assess the situation by collaborating with the emergency department quality improvement nurse who assisted me in collecting data on the time from door to doctor, the number of left without being seens, and the average length of stay in the emergency department. I also researched information from the Center for Medicare and Medicaid to find that left without being seens are now an important emergency department quality metric that is expected to be reported annually. Also, the Joint Commission has implemented performance measures indicating that no more than 10% of patients should spend more than 6 hours in the emergency department from arrival to disposition. After gathering data and research, I involved Dr. John Villani, the emergency department medical director, to assist in developing realistic outcomes and planning for the implementation of provider and triage. While working to implement process improvement initiatives, it is important to consider factors related to safety, effectiveness, cost, and impact on practice. Therefore, Dr. Villani and I collaborated with the assistant chief physician, the emergency department nurse manager, and the ED quality improvement nurse to determine what resources should be utilized for implementation. For example, we discussed where the PIT provider would be located, what equipment and resources they would require, how many nurses would be required to staff the area, and also we met to determine the hours of operation. To demonstrate collegiality, I shared this information with my peers and allowed for feedback prior to implementing PIT. Throughout this process, I demonstrated the ANA standard of ethics by collaborating with multidisciplinary teams to address the risks and benefits of implementing PIT in the emergency department setting. Since the beginning of this process, I demonstrated leadership qualities by verbalizing a clear and defined vision of implementing PIT to decrease wait times and left without being seen in the emergency department setting, while implementing measurable goals to evaluate progress. I have also exhibited passion and excitement for improving the veterans' experience and have worked effectively as a member of the ED team to achieve these goals. Most importantly, I have advocated for America's veterans to receive safe, effective, patient-centered, timely, efficient, and equitable care through the environment of the emergency department, no matter the severity of their condition. As a Christian, I believe it is vital to implement biblical principles into our daily activities and interactions with others. Therefore, throughout my research for this project, I also studied the scripture, which helps keep me focused on the overall mission. Colossians 3:23 states, "Work hard and cheerfully at whatever you do, as though you were working for the Lord rather than for people." I believe that by serving and honoring the men and women who are America's veterans, we are not only fulfilling the mission of the VA system and I Care values, but we are also serving the Lord by serving others. As nurse administrators, we must continually strive to improve the work environment and improve process flow so that veterans will view the VA as their provider of choice.